Welcome. This is Sophia Asan of the Reproductive Health Supplies Coalition, and we sincerely welcome you today to this webinar titled Review of Quantification and Landscape Assessments for Abortion Commodities. This webinar is hosted by the Coalition's Safe Abortion Supplies Workstream, which is housed within the NERT caucus, the New and Underused Reproductive Health Technologies caucus. We will have two presentations today for you. A couple of housekeeping notes. Please feel free to enter your questions or comments in the chat at any time. Also, kindly do keep yourselves muted unless you're speaking to the full group. And now I am pleased to hand off to the SAS Workstream co-chair, Natalie Kapp.
Hello, everybody. Welcome to our webinar. It's with much pleasure that I'll present our first presenters. We have two people who will be presenting to us on a landscape assessment of the availability and quality of medical abortion medicines. And after their presentation, I will then introduce our next speaker. So our first speaker today is Laurence Laser, who's a technical officer in the Prevention of Unsafe Abortion Unit at the World Health Organization. She specializes on medical abortion medicines, including initiatives aimed at increasing the availability and improving access to quality assured medicines. Following her introduction, Natalie Williams, who is a vice president at VSHD. She is an experienced public health professional with a background in maternal, reproductive, and indigenous mental health. She leads VSHD's work assessing availability of medical abortion commodities in partnership with the World Health Organization. And with that, I'll turn it over to Laurence.
Thank you, Natalie, and good afternoon, good morning, everyone. I'm very happy to introduce this presentation of WHO's landscape assessment of the availability of medical abortion medicines that I'm co-presenting with Natalie. Next slide, please. So first, let me give you a little bit of background. So we all know that the availability of quality assured and affordable medical abortion medicines is very important for access to safe medical abortion services, but also provision of comprehensive abortion care. In that context, WHO and CEDA held a technical consultation back in 2018. And one of the outcomes of this consultation was the need for conducting landscape assessment to look at the availability of medical abortion medicines through a wide lens that span from supply to demand. And this landscape assessment work fits within the global country support work that WHO is doing. And the reason for this landscape assessment was really to generate evidence that can be used in policy dialogue and policy making by countries, and evidence that fits within the context and the needs of each of these specific countries. So the work started in 2019, and so far we've finalized 8 country assessment in 2020 and another 9 country assessment last year. So this presentation will focus on the last 9 countries, and we are still finalizing 5 additional countries. And one of the take-home message of this work is that these assessments and reports have been very well received by not only our WHO country offices, but also the government partners and the NGO stakeholders. Given the cross-cutting findings of this assessment, it has a very high potential for specific country action and impact. And this is why the virtual offices uses them now to work towards increasing the availability and improving access to safe medical abortion medicines and services. And now I will give over to Natalie to present the methodology and results of these assessments.
Thank you, Laurence. Next slide. So I just want to briefly build on what Laurence was speaking to and talk about the objectives of the assessments and then the framework and then some of the cross-cutting findings. So the objectives were threefold for each of these country assessments. We were going to be documenting national experience related to the availability and the use of medication abortion commodities, specifically mifepristone, misoprostol, and the CombiPack. And then to both identify the barriers hindering availability, as well as identify the opportunities for increasing the availability of quality assured co-packaged medication abortion products. And as Laurence mentioned, this is mainly focusing on the nuances and specifics of the most recent country assessments, which were the 9 countries that include Botswana, Burkina Faso, Central African Republic, the DRC, Eswatini, Lesotho, Namibia, Uganda, and 2 states in India, Rajasthan and Tamil Nadu. Next slide. We used a framework, an availability framework, and we define availability as a woman's ability to request and receive a quality service and product when and where she needs it. And in order to organize our query and our data, we used our availability framework, which was actually informed by 2 other conceptual and analytical frameworks that consists of 5 pillars that impact availability of any healthcare commodity. And those are registration and quality assurance, policy and financing, procurement and distribution, provider knowledge, and end user knowledge. And under each of the pillars, there are a number of indicators we're looking for. Specifically under the registration and quality assurance, we're looking for which products are registered and which are quality assured, what are the medical indications for those products, and what's the registration process. For policy and financing, we're really trying to find out if medication abortion is integrated into the policies and programs, and what is the financial commitment by the government. So we're looking at the maternal health strategies and if they include unsafe abortion, what's on the essential medicines list, what are in the protocols for clinical guidelines if medication abortion is mentioned, is there a budget line allocation for MA commodity purchasing, and if they've ratified the Maputo protocol, just to name a few of the indicators. For procurement, we are looking at both public and private sectors. We were looking there to assess the volume procured and distributed, what are the distribution channels, costs of the products, and if it's included in the public sector procurement tenders, and what are the forecasting mechanisms. For the provider knowledge, we are trying to ascertain if providers know about the availability of the products, what is in the policies and the laws, as well as what are in the actual clinical protocols, if they're aware of all of those pieces. And for the end user knowledge, in this study, we did not have the capacity to really survey. So we rely a lot on the literature and studies that focus on knowledge, attitudes, and practice, and any partner data on focus groups that were conducted, as well as interviews with providers throughout to assess what their clients' perceptions were. So the study was broken into 2 phases. The first phase is the desk review. And that includes looking at secondary sources, basically going over the government reports, national documents, laws, guidelines, protocols, any data from the National Family Health Surveys. That is included in the first phase. And the second phase are the primary data is gathered through the in-person interviews, key informants that represent ministries of health, commercial drug manufacturers, nonprofit organizations, clinicians, academics, professional societies, regulatory and procurement agencies, and non-government organizations. So that is the second phase of the assessment. There is a limitation. Obviously, this was conducted during the pandemic. So interviews in the 2019 first 8 countries, which were in person, were largely done virtually or via phone. And sometimes it was really tricky to even get people to interview. And so in that case, some interviews that couldn't be secured, it was limited to public available documents or expert feedback only. Next slide, please. So the cross-cutting findings from both the 2019 and or the 2020 and the 2021 countries were very similar in some findings. But specifically here, regardless of the legal framework, the MA commodities can be successfully registered. This was something that was found in both sets of the studies. In this case, Uganda was a perfect example because they have a very highly restrictive abortion law, and yet there were 5 quality assured combi packs registered. Similarly, we found quality assured combi packs registered in the DRC and Burkina Faso, and then there were products registered as well in the 2 Indian states. In misoprostol, similarly, was found registered in nearly every single country, with the exception of the Central African Republic. But it was not always for obstetric indications. For example, in Eswatini, it was only registered for gastric ulcers. So the other major finding is the fact that the dissemination of revised legal frameworks and updated guidelines tends to really lag and is too slow at this point, which really lends to the downstream issues around service provision, providers not knowing about changes and therefore are unable to provide the services. And this we found to be a real challenge in countries that did not have an active presence of a partner working specifically in safe abortion work. So we really found that in the SADC region, where countries like Botswana, Namibia, Lesotho, and Eswatini, there was a real struggle right there to get in terms of how service provision was working, and the impact of not having a partner really impacted the fact that there wasn't any combi packs registered in those countries. So also moving on to essential medicines list, the key is a key policy document to justify public sector procurement. So what we found here is that the public sector procures from the essential medicines list in all the countries. There was an exception in Burkina Faso, where misoprostol as well as the combi pack was on the essential medicines list and it had not yet been procured. However, during our key informant interviews in 2021, it was shared with us that combi pack was on the supply plan for purchase, yet the precise date of when that was starting was not yet known. So it was definitely something that they were looking for, and they were definitely going to use that to procure in the future. It was also not procured in the Central African Republic, and that has a unique situation, in which case CAR has the central medicine stores had been bankrupt since 2011, so they rely heavily on donor driven product for their public sector procurement. However, it should be noted that in the EML, oftentimes there still needs to be advocacy done. It's not a procurement list, which is the ultimate determinant of products being procured. So in some countries, an additional Venn classification system for the EML in determining products that is vital, essential, or non-essential exists. And so even if it's on the EML and determined as non-essential, it will likely not be procured or put onto the procurement list. So further advocacy needs to be done to change the product Venn classifications if necessary, or additionally can be personal preference driven, meaning that there is a limited budgets and often key personnel in charge of the procurement list make decisions without much consultation. So products can get excluded if there's not close follow-up. So it's something to definitely, and that happened in one of the countries we were assessing. So something to keep in mind. Misoprostol was definitely on all the essential medicines lists with the exception of Botswana. But I did want to highlight that Burkina Faso and the DRC were the only two countries in this assessment where combi pack was included on the essential medicines list. And then I included Nigeria and Rwanda here, which were not countries that were in this assessment, but they offered two unique models in the previous assessment of how the combi pack can be included onto essential medicines list. One with Rwanda being this very pragmatic process where they had revised their penal code and then wanted the gold standard, so therefore included the products on their EML, where Nigeria took a different approach and used much more advocacy and evidence-based presentations to include that in consultations. And then the last finding here was that in countries with small populations, which I had alluded to above, and didn't have a strong partner presence with MA commodities, they would really benefit from a pooled procurement opportunities that can exist. Next slide, please. So some of the barriers, I think these are all going to be familiar with everybody on this call, but they're important to note too, because they're consistent across the board. There's insufficient data on unsafe abortion, and that really contributes to lack of political will. A lot of times there was things not being captured, or in countries with very restrictive abortion laws, it's inaccurate due to the fear of deterring women from coming to clinics for essential services, and therefore just creating that spiral of not having the political will because nothing is documented and the politicians are not seeing the need to address the change. And also in the strict countries with strict legal framework, the public sector tends to, or the private sector is largely where medication abortion remains as a service. Stigma consistently remains a hurdle in availability, negatively affecting service provision. There is the fear of litigation that from providers, therefore driving kind of the service underground and having women pursue unsafe practices. We found that the legal process for access in cases of rape and incest is often not well known among both providers as well as law enforcement. There was a real unclarity if the court order was needed or how to even obtain it, or in some countries, they identified that the link between the legal and health systems was just vague and unclear. And it seemed that protocols were really not known beyond the provision of emergency contraception. And then in the case of India, strict monitoring of medication abortion drugs in pharmacies to prevent sex-selective abortions was a deterrent because it was de-incentivizing pharmacies to stock, not to stock because of hyper monitoring and fines for non-compliance, despite the fact that MA was only indicated up to 9 weeks before sex selection was even possible. There's insufficient provider training relative to population size, which creates gaps in the provision, and the uptake of the WHO evidence-based guidelines on the use of MA up to 12 weeks is really low, usually driven by the national regulatory authorities' approval up to 9 weeks per manufacturer guidance. So there's a lot of confusion in product inserts as to what is accurate. Next slide, please. So the opportunities that exist, Laurence touched on what we're doing with these assessments as one of the opportunities, and I think that that's exciting. What we're finding is that when we go in and get to speak with these people in country, the stakeholders and the ministries of health are really interested to know the findings. So an opportunity is to really create some dissemination meetings among these groups to share these findings, and they could hopefully serve then as a guide for country implementation plans for stakeholders and partners alike to look and see how to improve availability. Some of the key opportunities we're seeing, each country is unique and different, but some of the key opportunities we're seeing is the potential to fund a potential safe abortion focal person that can align national policies and the provision of MA services and capitalize on those advancements and potentially changed legal frameworks. And then the opportunity, as mentioned above, with the pooled procurement for certain countries that have really low minimums that they could not procure enough product on their own, that they could utilize those pooled procurement opportunities. Prioritizing and strengthening and expanding access to MA through provider and community awareness. What we found is the OBGYN societies really play a leading role in training and education. And so FIGO's Advocating for Safe Abortion project would be a really synergistic opportunity for expanding awareness and education in countries right now, as well as other opportunities to really do training. And then at the global level with manufacturers to update the clinical evidence and product inserts for MA up to 12 weeks gestation would be another great place to start. And that last slide. And this is just wanting to acknowledge that this work was done by many. There's been a lot of people, and we wanted to say thank you to the time and commitment for all the organizations and government entities that helped to support that work, as well as the HRP program, which was the technical and financial support behind this.
Great, thank you so much, Natalie. That was fantastic and gives us a lot, I think, to think about. And just to let everyone know, I think Sophia said it, but we'll be taking questions at the end of both presentations. So I'm just going to move us to the next speaker. And this next part of the webinar will be addressing the process of implementing the first quantification initiative of abortion commodities in the Democratic Republic of Congo. And our presenter is Dr. Mike Mapui, who is currently a program manager at Ipas, DRC. He's a medical doctor and public health expert with over 10 years experience in technical leadership and health system strengthening. And with that, Mike, why don't you go ahead?
Thank you, Natalie, for the presentation, and thank you to Natalie William for the first part of our discussion. So I'll be sharing the little experience about the first quantification, which was carried out in DRC, Democratic Republic of Congo, alongside with the Minister of Health and other different stakeholders. Next slide, please. So the Democratic Republic of Congo is going like through policy and law change. We had a very restrictive law and laws and policies. We had a penal code of 1940s, which was punishing abortion, and even people who were providing information on abortion was like arrested, and everyone who were like selling or providing or orienting people to get product for abortion were like arrested. That was like the restrictive law that we had in the past. And currently we're going through a shift of legal framework where we have the Maputo Protocol that is allowing abortion service in case of rape, in case of sexual abuse, and in case of when the pregnancy is threatening women's physical and mental health, or women and or fetus life. In those conditions, women can have access to abortion. So that was policy, but we needed to have that policy to be or law to be transformed in abortion service at the health facility level. So that was what was done through from 2018 to now, to get those policies transformed in health service. And we had to work on making available the products, the commodities, abortion commodities, so that service can be really available at the health facility. Next slide, please. So this context is kind of known. We have about 61% of pregnancies are unplanned in DRC, and 43% of those unplanned pregnancies ends in abortion. And we have about 95% of abortion procedures which are performed using traditional and chemical concoctions, and 64% of performed abortion are done like in unsafe, we're using unsafe methods like sharp curettage in the health facilities. So that is coming from a survey that was conducted by the Minister of Health in 2018, which came up with these statistics. Next slide, please. And you can see that unsafe method was still used, like traditional concoction and sharp curettage. So that there was a great need to have the appropriate drugs quantified, made available so that it can be used in the health system. That was like the opportunity to conduct this project, which was to support the DRC government to integrate forecasting and quantification of safe abortion commodities into national level planning process for SRH commodities. So that was the main goal of the project that we conducted in DRC. And it was a project that was designed to have a long-lasting effect, like in terms of integrating that approach in how the health system is working now and make it sustainable. Next slide, please. So there was, as we said, opportunities to implement this project. We had the change of legal and policy framework. We had the political support and leadership, and we had local expertise like providers and supply chain staff like available at the country level who were already working on some other quantification processes. So that was opportunity for this project. Next slide, please. And we had some challenges. Mostly it was COVID-19, because the project was implemented throughout that period. And the individual knowledge and agency is weak at the country level, because you have people who are mostly using traditional knowledge, traditional concoction and drugs to heal or to provide care to people. And it was to shift and to bring those people to understand that we need to replace the unsafe and not proved commodities by like reliable and appropriate commodities for abortion. And we had community and social norms and support, which was really weak too, because as I said, in the African communities, people might sometimes be really conservative and would not allow women to have access to good quality abortion, because for them mostly it's stigmatized, and the health information was not available, was not raising or emphasizing on abortion data or statistics. So that was the context in which the project was being implemented. Next slide, please. So the implementation model, we had three trunks that we were making sure that we go with throughout the implementation of the project. The first and the most important was strengthening the national ownership, because if the intervention is not in line with what the country need, at some point it can be like a punctual intervention, and after that, you know, it's abandoned by the country. But we had to build the national ownership around the quantification of abortion commodities. So we had a baseline assessment to identify and analyze all available quantification tools and resources, and highlight the gaps and strengthen the capacity of supply chain staff to work on abortion commodities. Because you'll see that when it is about other commodities, people are okay, but when it is about abortion commodities, there is always need to clarify people's values. So that was a key element in this project. And we had the technical advisory group set up by the MOH to roll out the abortion commodity quantification. And the other trunk for this implementation was the quantification process and tools development, which was like the main element of the project. And we conducted an assessment of the availability of abortion care data at the national and local level. We did the tools development, integrating the findings from different assessments, and we finally ended by the national quantification forecasting exercise. And has next step, or how to make this sustainable. So we plan for the advocacy for the procurement of commodities, like for the dissemination results of abortion commodity quantification and forecasting exercise, and then, you know, fundraising and get the drugs provided at the country level, and the capacity strengthening of supply chain, healthcare providers, involvement of private sector, like pharmacists and other people involved in the availability of abortion commodities. Next slide, please. So to strengthen the national ownership, we had to co-create the project idea with the MOH, considering the programming gaps and the additional value of the project output. Reflections with the MOH on the strategy to roll out the intervention at the country level, and local expertise was promoted and strengthened throughout the implementation of this project, and the support to the MOH in the quantifying and forecasting of abortion commodities, and catalytic actions to call the different stakeholders to work toward the procurement of abortion commodities at the national level. national and local level, and integrate the abortion commodities in the national list of drugs, subsequently sustaining the approach. This was to build the national ownership. Next slide, please. And the next action was to start the abortion commodity quantification process and develop the tools. Next slide, please. So we started first by identifying the existing tools, a meeting with the Ministry of Health and gathering different stakeholders like other international NGOs, WHO, UNFPA, and other stakeholders working on abortion questions in country. We get through it and we went through the different quantification tools that were available at the country level. And that was a way for us to do a kind of a review of existing resources. We went through the standard guidelines that DRC had just like developed about comprehensive abortion care, and some other resources like Good Matcher and USAID resources on quantification, and conducted like a baseline. We developed resource and tools to do a baseline to know exactly what was the situation of abortion commodities at the local level, in health facilities, at health zone level, in pharmacies, and all of that. So that was the key element, to have a kind of big picture of what is the situation on the ground. Next slide, please. So the baseline, mostly the objective to identify the different site piloting comprehensive abortion care and highlight the different resources of abortion commodities at the country level, and review the health facilities and pharmacies case load and consumption, and assess the availability of the combination of misoprostol and mifepristone. And we did like a comprehensive review of the different documents and records available at the health facility level and pharmacies. And then we visited about 440 health facilities, which are spread out 26 provinces of the DRC. Next slide, please. And the baseline showed up these results. Like in the health facilities, misoprostol was available in all the 440 health facilities across the country, and mifepac, the combination of misoprostol and mifepristone, was available only in 50% of health facilities and provinces that we visited. And the MVA was available in some health facilities in 19 provinces out of 26 provinces. And sharp curettage was still widely used in health facilities. And the CAC data was not collected at the health facility level. The post-abortion care information available was really good, low quality, and the consumption logbook was with no record of abortion commodities. So mostly misoprostol, for example, it was listed on it just for emergency obstetric and neonatal care. And in the pharmacies, as you can see, Cambipac was available only in 4 pharmacies out of 151 pharmacists visited. So we came to the conclusion that the quantification using demography data is identified as the appropriate for the initial exercise when abortion data are not available or low quality at in the National Health Information System. Next slide, please. And this, for the development of the quantification tool, as I said, the MOH did set up a technical advisory group, which was gathering like experts from different direction of Ministry of Health and specialized program, and people from NGOs that are working on the availability of abortion commodities such as DKT and UNFPA. So the tool which was developed and presented to different stakeholders is an Excel-based tool with 6 sheets. It has a sheet of guidance, general information, quantification using demographic data, using case law data, and commodity consumption data. And the last page is about the summary of result. And the process was to first gather all the demography information, like total population, women in reproductive health, women expected pregnant in the year, and some clinical data like percentage of post-abortion care, comprehensive abortion care, procedures performed with medical abortion, and MVA. And all these information was input in the tool to have like a result come out, and that result will be triangulate between the 3 different methodology of quantification, like using demographic data and case load, and then commodity consumption. And then the 4th step was the reconciliation regarding expected percentage of facilities providing abortion services. Because when it is a starting program in a country where abortion was, for example, criminalized, you need, it's not all the facilities that will be providing abortion service. So you need to identify the percentage of those who will be starting in the first instance and quantify according to that. Next slide, please. So the quantification exercise was done within 4 days with the different stakeholders as listed here, and it gave a result that will be presented shortly. But what I would like to mention here is the involvement and commitment of the different stakeholders to see the first quantification occur in the country, and to work without reliable data, but mostly focusing on which exists in terms of survey, in terms of information in different resources, and work to gather them in one document and use that for quantification. So it was really, I can say, tricky and process, but they were all committed to work on it. Next slide, please. And here are the results from the quantification. For the quantification use demography data, we came up, the tool gave these like quantity of commodities, and these quantities are for 100% of, like if 100% of health facilities were providing abortion services. So this is the quantity of combination of mifepristone, misoprostol, and MVA. And for the demography quantification, as I said, it represents 100%. And for the consumption and caseload, as you saw, we've mentioned that the data available was low quality, so it couldn't help really to have a good reference for the triangulation. But we had to mention it here because the tool is set up to have the 3 methodology, so that at the end people can have possibility to analyze what was coming from each methodology and have the possibility to do reconciliation. Next slide, please. And here is the consolidated quantity of abortion commodities in DRC when we considered like 30% of health facilities who were expected to be providing emergency obstetric and neonatal care. that integrate comprehensive abortion services at the national level. So the reconciled quantity for the combination, for example, a combi pack, it's 271,650 like pills, which it's in term of units. And for misoprostol, it is in term of pills, and the syringe, it's in term of units. And this was done for the next 5 years. I've listed here only 2021 and 2022, but we have the forecasting for the 5 next years. Next slide, please. So the lesson learned from the project is that the success and sustainability of a new approach requires the involvement of all those concerned in the dynamic of change to support and impact the availability of abortion service at all levels of the health pyramid in the country. A long-acting and sustainable quantification process is a key element, like to have that sustainable. The personal beliefs and conviction have great impact on professional responsibility. The abortion commodity quantification approach needs to integrate the value clarification for abortion attitude transformation. And the use of technology like smartphone, WhatsApp, Zoom really helped us to achieve the goal within the COVID-19 situation. Next slide, please. So these are what we achieved in the project. So we had a supply chain evaluation with the MOH and other stakeholders. We designed the new tool and resources based on identified gaps and needs, and abortion commodities enlisted in the national list of essential drugs. Abortion service and commodity data are collected. National abortion commodity quantification and forecasting has been implemented, and national ownership on the quantification strengthened. Abortion commodity will be quantified alongside other commodities. Last one. So in the next step, I think it's mostly to continue strengthening the capacity of the supply chain at the national level, and make sure that we keep transforming the attitude of supply chain staff and the MOH level to make this process sustainable in time. Next slide, please, and the last one. Yeah, so those are just the next steps. So it's mostly to introduce in the private sector, like the combi pack, and create indicators to be included in the National Health Information System, which is a key element to improve the quantification methodology based on the real consumption and caseload than only just on demography data. So thank you so much for the time. Thank you.
Thank you, Mike. This is Petra, the other SAS co-chair, and I'll be jumping in to moderate the Q&A session, which we only have 13 minutes left for, with some really full presentations there, both from colleagues at HRP and Ipas. So before we've got quite an active Q&A going on in the chat, but I'd like to open up the floor to all participants. If you have any questions for Laurence, Natalie, or Mike. Okay. Oh, I see Emma, you have your hand up.
Thanks, Petra. My question's for Mike, and apologies if I missed this on the next step slides, Mike, but was just wondering if the Ministry of Health has plans to use the quant to procure commodities for public sector distribution this year or next year.
Thank you, Emma. I think that is still what we're advocating for. there is like several organizations that are working to advocate with the Ministry of Health to put a line in their budget for procurement of abortion commodities, but it is not yet decided. So the discussion are ongoing, but for the time being, I think we're talking more with UNFPA indicative to see how we could work with different donors to get the commodities made available as quantified.
Thanks, Mike. I see a question in the chat that I will throw out. It's for Laurence and Natalie Williams. How was, from True Overholt, how was quality assured, or the definition of QA you defined in the landscape assessments that have been undertaken?
Yes, thank you, Petra. I can take this one. I don't know if Sarah has something to add after, but so quality assured products is defined by both WHO procurement policy and UNFPA procurement policy by being either WHO pro-qualified or approved by a stringent regulatory authority. And in some exception, if there is no availability of either pro-qualified or SRA approved medicines, then there is the UNFPA expert review panel that comes in and that can also evaluate the quality. It's not really a quality assurance process, it's more a risk assessment process, and it's temporary, but it's the process that steps in if there is no other products available. But the short answer is either pro-qualified or SRA approved.
Thank you, Laurence. I actually, unless anyone has another question, I have another question off the back of that one on one more clarification. So for the landscape assessments, in countries where, say, for example, there were no QA products available, is the result or the outcome in that assessment reported that there is no quality assured product in the country? Is it sort of quite black and white in that respect?
I would say no, it's not that black and white. There's more information to it. So if there is no pro-qualified or SRA approved product in the country, there is still information about what other products are available, whether they are registered by the national regulatory authorities or not. And also there is some information about the products that are in circulation in the countries, whether it's through public or private procurement. So there is it's not the only information you can find, but maybe Sarah, I don't know if you want to add something to that.
No, that's accurate. Yeah, we look at the entire landscape of availability. So we start by looking, are there any quality assured products and which ones are those? When were they registered? Because as you know, the registrations need to be kept up. So sometimes we'll see a product was registered, but then they didn't redo the registration. And so that would expire. But so we would look at everything in terms of date of registration, quality assured, products that were assured by a national regulatory authority. And then, like Laurent said, what's coming in, like in the situation of CAR, where they didn't have any misoprostol product registered, they actually did have misoprostol available in the country that was coming in through MSF. And so in that case, we looked at what was MSF procuring through their international procurement agency. And we would highlight that as this is an opportunity to potentially expand access via this product that's already coming in through MSF.
Okay, well, that's super helpful. I asked because, as we know, for medical abortion, it's in a lot of cases where there isn't, a quality assured product available, other products are still being used. So that's really interesting. I saw a question in the chat from Eleni from Chai, and I'd also noted this one down. Are the landscape assessments going to be made public? Are they going to be published? And if yes, is there an estimated timeline for that, for the publishing?
So I think that one's for me. Yes and no. No. So there are already they have already been shared with our country offices, with our country partners, with limited stakeholders in the countries where these assessments have been conducted. But we are also planning for a wider publication of these assessments, and we are also preparing evidence brief because these assessments are super comprehensive and very big, and we sort of fear that nobody will read it when they see it's like 70 pages. So we are at the moment we are preparing the publication of both the full reports and evidence briefs, and hopefully we can do that this year to publish all these assessments that were finalized until last year at least, and then those that are still ongoing this year, we'll see if we can also publish them this year or early next year.
Great. I see a hand up from Lucy. We have a few minutes left. If you want to unmute and go ahead. Lucy, you're muted. Ooh. I'm trying to think.
Lucy, you should be able to unmute yourself.
I don't think she can hear us.
No, we still don't hear you.
I don't think she's even here. Yeah, I don't think Lucy's hearing us. I've just sent her a direct message.
Lucie, on ne peut pas t'entendre. On ne peut pas t'entendre, oui.
Ah, ok. Ok. C'est bon maintenant?
Yes.
C'est bon. Ok. Mike, tu vas m'aider. J'ai vu les rapports que tu as présentés et ces félicitations et les données sont très intéressantes. Mais mon souci, je ne sais pas, est-ce que vous avez partagé ces données avec les niveaux nationaux? Parce qu'à ma connaissance, le MEFIPA qui est inscrit sur la liste des médicaments essentiels, oui, j'ai vu les résultats de quantification que vous avez réalisés avec les PNSR et autres. La grande difficulté, comme tu le sais, c'est les manques de plans d'introduction au niveau pays, et nous sommes en train de nous atteler pour voir comment élaborer ces plans d'introduction et passer à d'autres étapes. Je ne sais pas si vous avez partagé ces rapports avec tout le monde. Sinon, il serait quand même intéressant qu'on puisse trouver un moment d'en discuter avec les PNSR lors d'une réunion de septembre, par exemple, pour que tout le monde soit au même niveau et qu'on puisse voir les actions futures à mener d'une manière coordonnée, quoi, ensemble.
Merci, Lucie. So Lucy is saying that thank you for presenting the report, and the different like information are really like exciting to see that at the national level we can have this, and that it is a great opportunity for CHAI to at country level to work closely with PNSR and Ipas and others to make like the process move forward. So she's asking if the report was shared with all the stakeholders, and if not, that should be done, and if we could have a possibility to have a joint meeting with all the stakeholders and talk about this. Lucie, je pense que merci pour ta question. Je pense que c'est quelque chose qui est important. On pourra sûrement avoir une réunion avec toutes les parties prenantes. Le PNSR est c'est le PNSR qui chapeaute ce processus. Et je suis sûr qu'on pourra sûrement, il y aura un groupe de travail sur l'avortement au cours duquel on pourra discuter beaucoup plus de ces différentes questions. Mais je suis d'avis et je pourrai sûrement vous partager le rapport.
Merci, Mike. Thank you very much. Do we have time for one final question? I don't know if there's any, I just need to pull up the chat.
I saw another one in the chat.
Yeah, go for it, Laurence.
Yeah, so thank you for that question. That's actually really interesting. So Saumya was asking about the reclassification of stringent regulatory authorities into the new WHO classification, which uses maturity level 1, 2, 3, and 4. And the maturity level is established by the WHO Global Benchmarking Tool. My understanding of this process is that at the moment, all the regulatory authorities that are that were defined as stringent regulatory authorities are temporarily classified as maturity level 4, which is the highest one. And then all the other ones are going through this assessment process to see if they can join this maturity level 3 or 4, depending on what we are expecting from regulatory authorities. Level 3 can already be a maturity level high enough for some of the functions. And also what I understand from this classification is that you can be at level 3 for some functions and level 4 for some functions, or 1 and 2 and throughout the scale. And there are also different levels for vaccines versus medicines. So this is an ongoing process, and we haven't, in terms of defining a quality assured product, we haven't switched from using the terminology SRA approved versus approved by a maturity level 4 authority. But this is a very good comment, and I will definitely take this under advisement and discuss it with our colleagues from the regulatory units, which is when should we switch the language to using the new WHO language.
Thank you, Laurence. And thank you, Saumya, for that question. I think we are 1 minute over. So I will hand back over to Sophia to close out the webinar.
Thank you so much, Petra. And thank you very much to our great presenters today, and for all those who participated. We will send out the webinar recording as well as the slides later. And thank you again, and have a great rest of your day.
Thank you, Sophia.
Thank you, everyone.
Thank you, everyone. Bye-bye.
Bye.
Thank you.